Welcome to this. Good evening. Welcome to this session of live demonstrations today. What we are going to show you various views, then subsequently measurements, and finally your question answer sessions. I hope all of you are comfortable with this kind of a presentation. And I'll get going. Hello, my subject lying down over here. We have focused the camera on his chest so that you can see it categorically, like where to put a probe and how to do and basics of echocardiography. That's what the aim as on today is. Can you have the screen? By the screen is ready. Now, can you see both the screens together? Anyone can open his mic and tell me.
Yes, sir.
Okay.
Yes, sir.
Yes, sir.
Fine. So, if you look at the chest of this patient, can we get
Sir, it's not visible, sir.
Double click on Drop Institute, Mrs. Reena Dua. Now you can see the chest of this person. Here is a watch. This is 12 o'clock position. This is 6 o'clock position. This is 3 o'clock position. This is 9 o'clock positions. Correct? Here is my transducer. If you can see the transducer. This transducer has got an index marker, which is seen over here. You can see this line, which shows an index marker. Some of you can have a light on this particular sign, which is a sign for index marker. So what do? We are going to put a transducer on his chest at left third intercostal or second intercostal space with the index marker at 11 o'clock position. Now I'm putting the index marker at 11 o'clock position. Can you see this? I'm going to remove my hand, other one. This is my index marker at 11 o'clock position. And now you can see the complete view of echocardiography. I'm going to adjust a little bit. You can see the complete view. Here is RV. Here is anterior aortic root. Here is posterior aortic root. Here is AML. This is LA. Then PML and LV, interventricular septum, and LV free wall. Look very carefully, and my aorta is right in the center of my screen. If I drop a line into the center, it will cut across my aortic valve. And if I do my M mode, look, I can see the aorta measurements in this particular window. I'm not going to talk about that right now, but this is what the Plaques window is. Now, look at my transducer. If the footprint is looking towards medial sternum, look what exactly do we drive? We are driving an RV, RA inflow view. Here is RV, RA inflow view, and I'm going to come back and utilize my right hand now. I'm turning my transducer a little bit, a medial sternum shift, footprint looking toward medial sternum, and I'm going to get RV, RA inflow. Coming back again. Now I'm going to rotate my transducer 90 degrees. Same position, I'm going to rotate by 90 degrees. Now, once I rotate 90 degrees, this footprint has to look towards aorta. So if it looks towards aorta, what we get, parasternal short axis view at aorta. If I'm perpendicular, I'm cutting across mitral valve. Here is a mitral valve. If now footprint looking towards left hip, now I'm getting a papillary muscles. And finally, I'm getting the apex. So I'll show you the again. Left second, you can feel this tunnel angle. Just keep it close to this. This is Plaques Window. Footprint looking towards RVRA, we get RVRA inflow view. Then coming back, rotate transducer 90 degrees. What we footprint looking towards aorta, we are getting the parasternal short axis view at aorta. And for everybody who has attended the program before and those who have not attended it before also, here is aorta in the center. Here is a tricuspid valve. Here is RV. RVOT is a pulmonic valve. And you realize them much better when you are looking at this during motion, not in a static position. So now footprint is looking towards aorta. Then we go back and gradually footprints just at second or third intercostal space. This is my mitral valve. So I can do a planimetry in this mitral valve. Now this is my papillary muscles level. And finally the apex level. That's how it works. So again, plaques, RVRA inflow view, come back, rotate 90 degrees, let the footprint look towards aorta, and you can see a very beautiful left coronary artery over here. Here is a left coronary artery. Here is a right coronary artery. So this is right coronary cusp, this is left coronary cusp, and this is non-coronary cusp. We can see the leaflets of aortic valve also. So you can see a bicuspid anatomy of the aortic valve. There is a bicuspid anatomy of the aortic valve. And this is only when you realize when it is in opening fashion, not in closing fashion. So this is what the plaques view is. In this plaques view, I always emphasize that we should look for what? This is the basal anterior septum of the plaques view. This is the mid anterior septum of the plaques view. This is basal posterior wall. This is mid posterior wall. And there should not be any papillary muscle over here. This basal anterior septum is supplied by D1 branch of LAD. This is supplied by D2 branch of LAD. If it means by, if this is not seen, not contracting, it means proximal LAD lesion. If this is spared, then the lesion is after the D1 branch. So somewhere in the mid segment of LAD, and this is contracting. So this is D2 branch of LAD. If this is also not contracting, the lesion is almost in distal LAD. And that's how we say that how the lesion is. Similarly, another important issue of this view is we should be able to see any significant mitral regurgitation in this view. Now we see a very trivial, just tiny mitral regurgitation in this particular window. Now you can see this mitral regurgitation in this particular window. And
sir, good evening. Sir, sorry to interrupt you. Sir, my video is not playing from the start. I'm just waiting for it to happen, but it's not happening.
Just go out, join again.
I did it twice, sir.
Click on Veena, do a double click. There must be something wrong with your system. If you are playing with a mobile phone, possibly it will not.
Okay, sir. Thank you.
So this is what exactly we are able to see a mitral regurgitation in this view is. Similarly, we can look at an aortic regurgitation in this view. So if I happen to see an aortic regurgitation in this view is, here is the aortic regurgitation. There is no aortic regurgitation in this view. Then rotate transducer 90 degrees. At aorta, what do we see? As I said before, we'll be able to see a coronary artery left, right coronary artery. They are 2 to 3 millimeter in size. If I switch on my colors, This is the best window for looking for pulmonic gradients. And where do we keep a cursor? Distal to pulmonic valve leaflets. This is RVOT. Now look at the cursor at RVOT. This is the cursor at pulmonic valve. So if I have to take a pulmonic valve gradient, they are just distal to pulmonic valve leaflet. Any position that will hold true. Similarly, I can look at tricuspid vegetation in this view. Here is a tricuspid flow in this view. So I can switch on just distal to the tip of the leaflet. You can see a tricuspid flow. Here is the E wave, here is the A wave. Then next comes down, you can look at interatrial septum. This is what the interatrial septum is. This is left atrium, this is right atrium. And similarly, you can see both the branches of pulmonic artery. So this is right pulmonic artery over here and the left pulmonic artery over here. They are two different angles, so I have to angulate a little bit to see a branching of pulmonic artery. Here is a tricuspid valve. Here is an interatrial septum, and this is LA, this is RA. So very good view for looking at tricuspid valve flow velocities as well as looking at RVOT also. And most important thing is this is one plane where we can measure RVOT diameter. So I'm going to focus now. I'm going to go a space on the left hand side to measure my RVOT diameter. And why this diameter is required? When we look for QP/QS ratio, the most important thing which is required is diameter. Now I can see my pulmonic artery diameter. I can see my pulmonic valve over here. This is one hinge point. This is second hinge point. If you join this line together, they'll give you RVOT diameter. So I'm focusing on my RVOT diameter. Now you can see, all of you can see very well the pulmonic valve seen over here. And during early opening or when the pulmonic valve is open, the RVOT diameter is the maximum. So this is where the RVOT diameter is almost 2.44, 24.4 millimeters of RVOT diameter. Then I said pulmonic gradient, stenotic gradient. If I'm putting a cursor at this point and doing a continuous wave Doppler, what I will get? I'll get peak velocity, peak gradient. So if this is my peak velocity, the mine peak gradients are only 5 millimeters or more. Anything more than 25 is considered as abnormal. Similarly, if I have to get an RVOT VTI, so I'll keep my cursor before pulmonic valve, do a pulse wave, and this is what the pulmonic flow velocity pattern will get. Then when we trace this pulmonic flow velocity, we are going to get what? Pulmonic valve VTI. And with this pulmonic valve VTI, all of you will understand that we can calculate what? Pulmonic flow or stroke volume across pulmonic valve by utilizing RVOT VTI diameter, that was 2.4. Half of that is 1.2. Pi r square, pi is 3.414 into r square is r is 1.2 into square of it, and then multiply that particular value with RVOT VTI. Here is the RVOT VTI 12.65. So this is a stroke volume across pulmonic valve. Now from this view, I'm going to look at my mitral valve. Now this is the most important thing. Look, if you look at my aorta, now you can see a very beautiful LV. But my aorta is on the right side of my splenius. If I rotate 90 degrees, the aorta comes over here and the mitral valve is off, is not clearly seen. So what do? We bring the aorta almost to the center. Now this is aorta is in the center. I'm drawing a line right into the center of this curve. Then rotate my aorta in the center and then go towards mitral valve. Now you can see a beautiful mitral valve with both medial commission as well as lateral commission. And we can zoom up this value very well. And once we zoom up this value, and what do? Like I'm going to freeze this value and scroll a little bit. And finally, measure the mitral area by planing it. So here is a mitral valve area by planimetry of this subject. It comes out to be 1.17, which is not true. It has to be about 2.4 or 2.5. So we are going to do it again. Now you can see the mitral valve which is perfectly open. I'm just showing a clip. Now this is the mitral valve which is fully opening now. So this is lateral commission, this is medial commission. And once we freeze and open it completely, so this is going to be the mitral valve area for this subject. So I'm going to trace it now again. Is almost more than 4 centimeters square. Then next comes from this view, we go to papillary muscles level. This is the mitral valve again. You can see we go to papillary muscle level and then to apex, and that's how we complete our Plaques window in this subject. From this Plaques window, I'm going to go to the apex now. Look, in Plaques window, I was perpendicular. Look, I'm almost perpendicular. I'm going to remove my hand. Look, I'm almost perpendicular. But when I'm in apical window, left fifth intercostal space, I've got to be as parallel to the heart as possible. So I'm trying to be parallel to the heart as possible. So I'm going to be as parallel to the heart as possible. So I'm almost parallel to the heart in cut section. If I'm perpendicular, look what exactly I'm doing. I'm just cutting the apex. So once you see this kind of window, you try to become as parallel to the heart as possible. Then you have to make, this is 4-chamber view. Look at the index marker. Index marker is over here. Second or third intercostal space. I'm parallel to the heart. So this is 4-chamber view. Counterclockwise, counterclockwise rotation of the probe is happening now. It becomes 2-chamber. Further counterclockwise, it becomes 3-chamber. So if it comes back to 11 o'clock position, we are in 3-chamber and it looks like Plaques window in apical. Plaques view in apical window. So we go back to apical 4-chamber view. Index marker at 2 to 3 o'clock position, and let the footprint looks towards aorta. Just look at my view. Look at the image. Let the footprint looks towards aorta. So what did it do? I asked my footprint to look towards aorta, and soon I did that. The aortic valve opened up, and this is sometimes known as 5-chamber view. So this is one where we can really look at an aortic flow. So a lot of things to be said on 4-chamber view, 2-chamber counterclockwise rotation. So we are roughly at 1 o'clock position or 12 o'clock position. Then we are back at 11 o'clock position to label as 3-chamber view. Now the most important part is this particular wall. If this wall has got a papillary muscle, then this is truly inferior wall. If this wall does not show a papillary muscle, then this is a posterior wall. So here is a papillary muscle seen. This is 2-chamber view. This is anterior wall and this is inferior wall. Then I go to 4-chamber view. This is septum and this is lateral wall. And this septum and lateral wall, based on the insertion of papillary muscle, is divided into. Suppose this is a papillary muscle. This is basal septum, lateral wall, mid lateral wall, apical lateral wall. Similarly, basal septum, mid septum, basal septum, and apical septum. Rotate counterclockwise rotation. This becomes, whole of the wall becomes anterior wall. Basal anterior, mid anterior, apical anterior. Basal inferior, mid inferior, apical inferior. Then go to 3-chamber view, and here instead of 3 segments, we have only 2. Basal anterior septum, mid anterior septum. Basal posterior wall, mid posterior wall. And the same thing which I said during Plaques Window is, look at this contraction of the major anterior septum, D1 branch of LAD. If it's blocked, proximal LAD. If it's not, then possibly distal to it. This is D2 branch of LAD. If this is involved, it means the lesion is between D1 and D2, that is mid LAD. And suppose this is preserved and apex is gone. In that case, this is distal LAD lesion. Similarly, we look at four-chamber view. Four-chamber view, we have a lateral papillary mid and basal lateral wall supplied by LCX. Mid and basal inferior wall supplied by RCA. Apical inferior, apical lateral supplied by LAD. Rotate counterclockwise rotation. Mid basal and mid inferior wall supplied by RCA. And rest all four segments are supplied by LAD. And now go back to the same view which it is, the three-chamber view. And if you happen to go to five-chamber view, look, this could be a lateral wall, but this is certainly a basal anterior septum. This is no more a septum now. Now this supply is not from RCA. This supply is now from LAD. Another views which are very, very useful in this patients. Like we can look at the mitral flow velocity. I said mild MR. Look, he has got a mild MR. You can see this small trivial jet out here. Then second thing is we can look at the flow velocity across mitral valve. So I'm going to look at the flow velocity across the mitral valve. So if I measure this flow velocity, this is E wave, and I downgrade to bottom, and this is A wave. And look what does it give you? E wave 96, A wave 78. Dissociation slope, dissociation time is 195, and E ratio is 1.23. And there is small trivial mitral registration which can be seen as a Doppler flow pattern over here. If I keep my sample volume at this particular point, this is mitral valve annulus area. If I put my sample volume, so I can trace this mitral valve Doppler spectrum pattern. This is 21.8. This is VTI across mitral valve. If I can take the diameter of the annulus of mitral valve from 1 inch point to another inch point, this is 3.3. So I can get a stroke volume across mitral valve. Similarly, we can look at an aortic flow velocity. So I'm going to look at an aortic flow velocity at LVOT. This is at LVOT. So if I trace this Doppler spectrum pattern over here, this will give me LVOT VTI. If I move this cursor distal to the aortic valve, this is no more an LVOT VTI. This flow pattern, this is now a pattern across aortic valve. So what do I do? If a lasing happens, try to move the baseline up, increase the scales, which you can did it, and still I can't see this. So what I'm going to do is, I'm going to switch over to continuous wave down. I can see its flow velocity, which is almost 1.58 meters per second. So this is what we do in LV. Similarly, if I move my probe a little bit towards fourth intercostal space, so what exactly is happening? I've get rid of my LV and now I'm focusing on my RV. Now look, how does it happen? I'm in fifth intercostal space. I'm going a space up. And now I'm focusing exclusively on RV, RA. And now I'm going to switch on my colors. The flow volume across the distal to the leaflet. This is tricuspid inflow pattern. This is something like mitral only. So here is M wave, E wave, here is A wave. And if I go beyond this into the tricuspid regurgitations, now you can see a Doppler spectrum pattern. Below the baseline, I'll wait till I get a rounded or tongue-shaped pattern. Now I've got something like a tongue-shaped pattern over here. So this is one, the Doppler flow pattern starting from here and it goes back. So this is like tongue-shaped tricuspid regurgitation jet. Velocity 2.48, gradient 25. Nothing significant because up to 3 meters flow velocity regurgitation, we are not going to take them seriously. Another important part of this four-chamber view is look at the RV free wall. This is RV free wall. This is basal, this is mid, and this is apical. And if you look at this, this should thicken. Let me just go back to that phenomena when we talk of thickening, when we talk of motion. Now look in this view and look carefully. I'm going to change my colors so that you can see better now. Look this segment, this endocardium, which is thickening inside. There is no motion. This is thickening of endocardium, which is happening. So we have to look at thickening of the endocardium rather than anything else. So this is classically thickening of the endocardium. And based on this thickening, we talk of some abnormality. Look very carefully in this subject. There's some amount of hypokinesia in the apical septum. Look, thickening over here, thickening over here. There's less thickening or there's no thickening in apical septum. I'm going to zoom up for you, reduce my sector scale so that you can have better resolution. Now you can see, carefully look at this particular point. This point is not thickening at all. And as compared to this segment and compared with this segment, there is little less thickening as compared to this. As this kind of a less thickening is present, we always call them hypoconnected. From this particular place, we'll go to subcostal window. See the later. Now, his abdomen is over here. Now you can see his subcostal. Now this is his abdomen. So I'm going to put a transducer right into the abdomen with index marker at 3 o'clock position. And the most important thing is slightly towards the footprint, looking towards right shoulder. When you can't make any view, ask the patient or subject to take a deep breath. Now he has taken a deep breath. We can see his RV free wall, tricuspid valve, and RV. And if I rotate counterclockwise rotation, now look at my probe and look at my rotation. This is what I'm going to get as my IVC over here. So, now I'm rotating counterclockwise rotation. And here is I'm getting an IVC, very small IVC at this present moment. So this is what the views are. Now next view is keep his neck extended slightly towards, now I'm keeping his neck extended slightly towards right hand side. Index marker at 1 o'clock position, and we are as perpendicular to the possible as possible. Now you can see this is descending aorta, colors going away. Then if I tilt to left hand side slightly, right hand side, I'm getting this ascending aorta. Now you have to look very carefully by my hands movement. I'm going to fix up my hands movement for you. I'm going to take this off. Now this is slightly towards right side because aorta arises like this. Then I'm moving transducer slightly in the center and then to the left because aorta goes up, then dips down posteriorly and towards the left hand side. So index marker at 11 o'clock position, perpendicular, and now if it's slightly towards right hand side, I'm seeing my ascending aorta. This is my ascending aorta. This is arch of aorta. And now I'm moving a little bit. This is my descending aorta. And here is a pulmonic artery in between. So this is arch of aorta. This is ascending aorta. This is arch of aorta. And now this is descending aorta. And why this view is useful? You look for coarctation of aorta in the subjects. And where do we see a coarctation of aorta in this subject is, you can see a beautiful left subclavian artery. This is left subclavian artery. This is left common carotid, and here is right innominate. So coarctation of aorta could be preductal or postductal. So here is a ductus which is seen over here. Second important thing is, if you have to calculate coarctation of aorta gradient, this is the one window where we do a coarctation of aorta gradients. The flow velocity is almost 2 meters per second, insignificant. But this ascending aorta is very, very useful when we talk of the various gradients across the various windows, and we can look at a great gradients of aortic flow in this suprasternal window when we talk of a gradients. So this is all views which we have taught you over a period of time, whether it was plaques, whether it was short axis views, whether it was apical, subcostal, or suprasternal. Next comes measurements. I'm going to show you very few measurements which are relevant, because we'll be talking of these measurements again and again. I showed you RVOT. Let me just show you LVOT now in this subject. What I'm going to teach you is, which is a common consensus. So aorta, and look at this aorta, and you can see two leaflets. One is over here, second is over here, and both of them are initial opening phase, and this is further confirmed by this cursor marker over here. So at your level, what I always suggest is one hinge point to another hinge point. That's all is your LVOT. Don't go beyond that. Some people say 2 millimeter inside. I'm not saying that it should not be done, but at initial level, what you should do is, this is all which is needed at LVOT diameter. So one hinge point to another hinge point. This is 2.25, and do it as many times as possible. And which values they correspond together very well, that should be the ideal value for LVOT diameter. Next comes LV. LV and LA. So same window. When will be LA maximum size? End systole. Look at my cursor. My cursor is right now at end systole. So I have to measure this diameter of LA from this trailing edge to leading edge, and that is 4.19. And if we divide by body surface area of his, which is close to 2, this comes out to be 21 millimeter per meter body surface area, and 22 is the highest limit for LA size. Next comes LV dimensions. They are very, very important. And initially we used to talk about M mode measurements. Now we have started giving it up over a period of time. And I'm going to show what is the, how do we measure the LV now. Here is LV during end diastole. So it's a maximum dimension during end diastole. And we have to measure LV from the LV free wall, not from these papillary muscles cords. These are cords of posterior mitral leaflet. This is the cord of anterior mitral leaflet. So I have to measure from LV, basal LV, basal posterior wall to basal anterior septum, and that's what's 50. And if you divide by body surface area, it's come out to be 25. Anything more than 32 is considered as abnormal. Similarly, this is diastolic. Now we scroll the patients to systole and systole. It should reduce by approximately 1/3 of a size. If that was 40 to, sorry, that was 50, and now we measure it again. This point to this point, is almost 33. So truly speaking, 17 to 3 is 51. So 33% reduction of LV contraction, which is very carefully seen. Next comes, everybody wants to learn this particular phenomena of ejection fraction. Rotate. I showed you how to do a mitral valve, and now is ejection fractions. For ejection fraction, I have to have a very good delineating window. So I'm going to freeze it, move my cursor to end diastole. So this is end diastole. You can see the cursor over here at end diastole. Now I'm going to switch on measure. Measure what? Volumes. In volume, we go for biplane method, 4-chamber view. Then we start at the medial annulus, go across the black and white interface on an endocardial edge in relation to cavity. This is end diastolic volumes. Now I'm going to scroll it to end systolic. So this is what is end systolic volume. So I'm going to trace from medial annulus along with this border of endocardium. Go up, look at the endocardium of the other segments, come back. And now you can see the ejection fraction is almost 66%. You can see ejection fraction of 66% over here in 4-chamber view. I'm not very comfortable. So what I'm going to do is, as per guidelines, I'll see for 2-chamber view ejection fraction also. Because heart is not a single dimension structure. Heart is a 3-dimensional structure. So at least we should take 2 dimensions to talk about this particular issue. So I'm going to end diastolic volume 2-chamber. The machine automatically tells you. And you have to create all this machine. You'll have to sit with the machine persons to create all this problem in these machines. Next, scroll it. And somebody can ask me a question, what is the normal ejection fraction? I say 54 or more. But latest, they have come out to be 58 as a normal ejection fraction. Now, biplane ejection fraction, if you look at the screen on the left hand side, his ejection fraction by biplane is 61%, which is normal. Next comes very famous point, that was MAPSE and TAPSE. So I'm going to put a cursor line into the center and move. So what do I get? I get mitral annular plane systolic excursion. Okay, so we can measure this. Go up is almost 15, appears to be a little reduced. Similarly, we can go for RV systolic function. How do we look for RV systolic function? Is tissue Doppler imaging, and then we put a sample volume at pulse wave at right annulus. So this is TDI of right free wall, which is almost 12. Anything more than 9.5 is considered as normal. Similarly, you can do a tap, say, by cutting an M mode, you can drive a value of systolic function of RV. So this is, and there is a top of this particular phenomenon, which is 2.08, considered as normal. Like, don't consider the extraneous waves. I did not do this extraneous wave because they may have been coming from ports and other things. So I've taken a line, either you can take a line from here to here, or you can take a line from here to this point, whatever this issue is. So this gives you RV systolic function. And next slide, if you have a tricuspid regurgitations, we drive TRZ gradient, as I showed in the previous subject. So this is almost 2.5 meters per second, corresponding to 25 millimeters of mercury gradient across. tricuspid regurgitation gradient across RV-R. So we got the ejection fraction, we got the systolic function MAPSE, we got the TAPSE and RV free wall PVR. So now I'm going to show you what is tissue Doppler imaging. One fine science, what exactly he did. He made many people laugh to begin with. What exactly he did? This is tissue Doppler imaging. We have reduced the sector and just concentrating on septal annulus. Then we move to lateral annulus and take the velocity. The thickening happens from this. These are upside down images. So the thickening happens, these segment apex remains static. Mid and basal and other segments, they move toward apex for their own errant blood supply. So the segment will go up as we do a systolic function. The RV, LV systolic function across annuli is beautiful trace. So this is what RV systolic function is. This is almost 6 centimeters. Anything more than 7 is considered as normal. Another important thing is you can measure real IVRT over here. So this is S wave. This is isovolumic relaxation wave, isovolumic contraction wave, E prime, A prime, then isovolumic, contraction over here, relaxation over here. So I can measure by relaxation wave IVRT from this point to this point, which is it's from here to here, 65 or 64 milliseconds. You can do it as many times as possible from this place to this place of same 65 milliseconds. This is known as IVRT across septal annulus. Then one or two things more, then I'll start taking up questions because that will give you a sanctity of looking at this particular imaging quality. I want to show you mitral valve again. How to take a real cut section. Now this is very clear now. Now you can see a dancing mitral valve. So this mitral valve is, this is lateral commission, this is medial commission, this is anteromitral leaflets, and this is posterior mitral valve leaflet. Anterior mitral valve leaflet is divided into 3 segments. M1, M2, M3. P1, P2, P3. So there are 6 scallops of anterior and posterior mitral valve leaflet. And that's why you can see number of times, you can see a 2 mitral regurgitation jet originating in 2 different sector scans, whether it's 4 chamber, 3 chamber, or 2 chamber. So I'll stop over here, and one more thing I want to show, see the later. Again going to subcostal window. Again going to subcostal window, then rotating counterclockwise rotation, I should be able to get an IVC. Unfortunately, I'm not able to get an IVC over here. What do I do? Turn to this side. I'm going to, this is my IVC part, correct? So I'm going to put my probe in the same direction over here. Now I'm gradually seeing my liver. I'll start seeing my heart. I can't demonstrate over here because of not a good technical window. And that's what I wanted to show you. With this window also, you can look at your IVC. Because where the IVC is, if it's the heart over here, the IVC will drain from this point to this point. So let me try it once again. Number of times we do get it, number of times we just have a problem of getting them. But this is one which you can utilize in a day-to-day practice for looking at IVC wall representing volume 6. Now you can see beautiful. So this is IVC over. Right? See the later. I'll stop it over here for a minute. Pause करें. Okay, mitral hemorrhage, घूम जाओ. So I'm going to go to the Plaques window again. Then take my cursor on the tip of the mitral leaflets. So what do we get? Here is antisystole. So I'm going to draw cursor. Now see, look, this is antisystole. So this is mitral valve DE excursion. This is EF slope. We can measure this particular phenomenon. This is DE excursion and this is EF slope. And some people, they started looking at E point septal separation. What was that E point septal separation? This is E point and septum separation. This is 0.79. This is 0.7 or less in normal subject. And it could be up to 10 millimeters maximum. And after that is considered that LV is dilated. Anything else, Utpal?
Sir, in that Plaques view, below the LA, is it descending aorta?
Descending aorta. You're talking of a structure below LA is, this is descending aorta. And the best part is when you're in doubt, this is not descending aorta. This is dilated coronary sinus.
Okay.
This is descending aorta. Right?
Yes, sir. And sir, the aorta itself looking so much echogenic, is it a normal or it's kind of sclerosed or calcified? What we can say?
Now things have disappeared. I'm going to make it comfortable for you. Now it's not no more echogenic.
Yeah. Much better.
So it all depends on your hands, you know. Look, this is a bright image, more echogenic. This is medium. So this is normal image.
Okay, sir. Okay. Thank you, sir.
Okay, next one. Dr. Tushar.
Hello.
Yeah, go ahead, Tushar.
Sir, as we are seeing this M mode, what exactly the structure should be visible in ideal M mode? Because most of the time the center view is cubed. Either you see a better LA or either you see a better LV. Most of the time RV is not visible. So what exactly, what structure should be seen? Because papillary muscles are also seen sometimes in the Plaques view of M mode.
Look, this is the best M mode you can get in your imaging qualities.
Okay.
Look at my line. Did you see my line?
Yes, sir.
Okay. This line should intersect aortic valve. So
Okay.
I'm going to take an M mode.
Okay.
So it's giving you M mode of aortic valve.
Yes, sir.
I'll move my cursor to the tip of the mitral leaflets.
Yes, sir.
Now I'm just distal to the tip of the mitral for LV dimensions. Right?
Yes.
So the best M mode 2D image would be this is RV free wall here,
Yes, sir.
RV, aorta, anterior aortic root, posterior aortic root, interventricular septum, then posterior root is in continuation with AML. This is LA. This is possibly a dilated coronary sinus. This is LA free wall. This is LV free wall. And this is the descending aorta, which is similar. Anything else? Next?
One more, sir.
No.
Uh,
Go ahead.
in fatty person, when we do like so obese people, it is very difficult to get a proper Plaques view. So any tips for that?
Get to maximum penetration. That is the lowest possible transducer you have at your disposal.
Okay, sir. Okay, sir. And sir, one more thing. Before starting with the Plaques view, generally we see for the orientation of the heart in the subcostal view. So, sir, can I?
Adult patients we don't see. In
Okay.
pediatric we see orientation.
Okay, sir. Okay, sir. Thank you.
Because in adult we consider that everything would be normal. In pediatrics we consider everything would be abnormal.
So, but in cases of dextrocardia, they say that to look for that, you should first do the subcostal view and then start with the ORID.
For dextrocardia, why should do a subcostal view? Why should X-ray chest?
No, sir. If you are doing an echo, so I
Uh,
think that you should start with subcostal view first.
Agreed. Then if you know that we are going to scan dextrocardia, will start from a subcostal view.
Okay, sir.
And the patient then would be lying on a bed, facing towards your towards yourself.
Yes. Okay, sir.
All
Thank
right.
you. Thank you, sir.
Next, Dr. Tiam, are you there? Dr. Tiam. Next. Dr. Ghansham.
Yes, sir.
Okay, sir. Go ahead,
Yes.
Dr. Ghansham.
Sir, can you show me again MAPSE and where we have to put our cursor?
Okay, 100%. Everybody should look at it because you know if somebody is asking a question, this is one way like you are learning more. Now look at this, Dr. Ghansham, 4-chamber view.
Yes.
You have to be really in 4-chamber, not in 5-chamber. So I'm in 4-chamber view. Now I'm showing you where I should keep my cursor at the medial annulus. So I'm putting my cursor at the medial annulus. Line across medial annulus, right?
Yes.
Then M mode. His function is little less, no doubt about it. So this is systole, beginning of systole, and this is the end of a systole. What I'm measuring is, here is a point where I'm measuring, this is beginning of systole, and this MAPSE has gone up to this point. So my second point is at this point. So one point is this, second point is this, and this is almost 12 or 13.
Okay.
Normal is how much? 17.5 or more. At the same time, I must tell you, like we should also look for a systolic function of the RV free wall. So I'm going to move this MAPSE to TAPSE.
Okay.
Now is the tricuspid annulus. Can you see the tricuspid annulus now?
Yes. Yes.
Carefully now. This is 2.27. Anything more than
0.5.
15?
1.7.
1.7 is considered as normal. And sometimes if you can't see a good lateral medial annulus, you can go to lateral annulus. Now can you see the lateral annulus MAPSE?
Yes, sir.
So this is also mitral annular place systolic excursion. Clear?
Yes, clear.
Anything more, Dr. Ghansham?
No, sir.
Sir, sorry to interrupt.
Go ahead.
Sir, in M mode, what all can you please identify the structures, like what all is visible in that view?
Okay, just give me a second. This tracing you are talking about?
Yes, sir. What all, sir, can you please identify the structures?
Look, I'll show you that where I'm drawing the structure. So this is lateral annulus, right? Can you see this lateral annulus over here?
Yes, sir.
So this lateral annulus is represented over here.
Okay.
Above that lateral annulus, what we are seeing cutting the mitral valve. So this is the mitral valve over here.
Okay.
Above than that is LV cavity. So this is LV cavity. And this is above than that is LV apex. So this is LV apex. If I go down on this line from mitral valve and annulus, then what I'm cutting across descending aorta. So this is descending aorta.
Okay.
So you can look at your M-mode 2D image and correlate accordingly.
Yes, sir. Thank you.
Right? Dr. Ghansham, anything else?
No.
Thank you. Next. Dr. Damodar.
Sir, good evening, sir.
Good evening.
So could you explain again that E prime and E and A and the E slope?
Mitral M mode, which one?
Yes, sir.
M mode. Okay.
M mode, sir.
So I'm going to Plaques Window again. Cursor at one tip of the mitral reflex. Okay, beautiful image. We have got it over here. This is E point. Sorry, D point, E point. This is F point. So this is DE excursion. This is EF slope. This EF slope is reduced during mitral stenosis. This is opening of the mitral valve. This is a slope of the mitral valve. So both opening and slope will reduce in mitral stenosis. Then second is this is E point septal separation. This is septum. This is E point. So this is E point separation. So this is E point septal separation. So this is what is when LV gets dilated. This we have to look at E point septal separation. So this is what is in clinical use. This is what exactly is happening. This is all diastasis. And this is A and F most probably. I don't remember. I'm sorry. This has gone out of my mind completely. So this is initial emptying across mitral valve. This is totally a period of diastasis, and then came atrial kick, A and possibly F.
Okay, sir. Then one more question.
Yeah.
So you did a planimetry, sir, the mitral valve area which you measured. Exactly in which frame should we when should we exactly freeze the frame to get the
good, very good question. Let me go back and show you again, because we are live, so you can show as many time as possible. That's not an issue. Go rotate. Now we are in mitral valve. Can we see mitral valve very clearly?
Yes.
So when the mitral valve will be fully open, tell me.
Diastole.
Early diastole. Early diastole. So look at my cursor over here. This is end systole. This is early diastole. So mitral valve is fully open in early diastole.
Okay.
Similarly, aortic valve. When we measure the aortic valve, when we look at the aortic valve or we measure LVOT diameter, we always do the early system. Right?
Yes, sir. Thank you.
Next one. Dr. Rahul Kenkan.
Yes, sir. Actually, I have a few questions.
Go
The
ahead,
first
Rahul.
one is, yes, sir, while taking the subcostal view, how to differentiate between aorta and IVC by using color and the pulse wave?
See the later. This question is how to differentiate between aorta and IVC in subcostal window. Unfortunately, I'm not able to show him very categorically, but I'll try to show you images. First of all, aorta is posteriorly placed. Where is SVC and IVC? They are parallel to each other almost. SVC is on the left hand side, and aorta is on the left hand side, and IVC on a slightly towards right hand side. So best part is I will not be able to demonstrate this, but I can tell you that one structure which is correlating with RA. लंबा सांस लो, सांस नहीं करो, जितना रोक सकते. Good. So let's show this first. The structure which correlates with RA is IVC. Then IVC will have what? The flow of color will happen from this side to this side. So it will be blue in colors. Then it will have a respiratory variations. Third is, if you put a graph, it will show a respiratory variation. It will be collapsed with respiration. Aorta would be seen over here, just behind IVC, but that is pulsatile structure. Suppose this is color is blue, the blood will be flowing in this direction in aorta. So it will be red in colors. I'll maybe show in some other images. I'll show, just give me a second. Let me just find out an image that will help you in differentiating this particular phenomenon. Beautiful. What you asked for, you got it. Now I'm going to freeze this frame for you. Can you see the images? This is RA, right? Dr. Rahul, can you listen
Yes,
to
sir.
me?
Yes, sir. Yes, sir.
So this is RA, this is IVC, this is hepatic veins. And you do not have any colors in it. But if I move my frame from this, subsequently, now look, this is IVC, and behind this IVC, this is aorta. Now look carefully when the frame is moving. IVC, 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 and just behind it is aorta. It will come in a second. Yeah, it's aorta. If I go back, this is aorta. This is aorta over here. This is IVC over here. Then put a colors, it will be blue in color. There will be majority red in color. Put a sample volume, it will be a phasic, changing with respiration. This will be pulsatile. Is that clear?
So what exactly do you mean that it will be changing with respiration?
Changing with respiration is, look, this is changing with respiration. The larger size is becoming smaller in size.
Oh, yes, sir. Yes, sir. I got it.
Aorta will not change in respiration because aorta has nothing to do with the respiration. Let me go to
Yes,
the
sir.
previous over here. It's not going to do anything with the respiration. This is aorta over here. So it's not going to say anything with the respiration. But IVC will show changes with respiration. Clear?
Yes, sir. And also, sir, if we are getting IVC easily, should we ask the patient to sniff, or like should we just go ahead and take the measurements?
Now look, Rahul, the most important thing is when you suspect that IVC is dilated, look, in this patient, what do you suspect, normal or abnormal?
It is dilated.
It
Like,
appears
seems
to
to
be
be
dilated. Appears to be dilated. At this point, I'll just show you that somebody has measured the next frame in this patient. He has measured the next frame. So this is 26 millimeter dilated, and this is only 18 or 19. If this is 26, IVC is dilated, and this is 18, it means it has collapsed less than 50%, right?
Yes,
So
sir.
RA pressure is 15 based on this. If I ask the patient to do a sniff, if it remains as 18, then my RA pressure is 15. And if it reduces down to 12 or 11, then in that case my RA pressures are 10. So we do all this sniffing and all those kind of a thing when we expect that IVC is not collapsing more than 50% or IVC is dilated.
Yes, sir. The next question is, sir, identifying the anteromedial, the posteromedial and anterolateral papillary muscles in short axis. Like, should they be considered?
It's a very simple thing. I'll show you. It's not a difficult thing. I say you remember in a better fashion. Keep on looking at my views because this is more important. Keep on looking where I'm keeping with cursors. So rotate 90 degree. Aorta to begin with, as I said you, come back, mitral wall, and then papillary muscles. Now I'm freezing my image. So these are two papillary muscles. One over here, one over here. Now look at his motion. So how do we say which is medial, which is lateral? Correct? So this is medial, which is the center, or which is closer to RV. This is medial. Which is lateral? This is lateral papillary. This is supplied by circumflex. This is supplied by RC. Right, Rahul?
Yes, sir.
Next question.
And sir, while taking measurements in 2D, we are supposed to take it in trailing edge to the leading edge.
Right.
So, but sir, is there an exception while taking measurements across aorta?
Aorta in 2 dimensions echo, right?
Yes, sir.
So I'm doing with trailing edge to leading edge only. Here is trailing edge to leading edge.
Okay, sir.
In fact, exceptions come sometimes, like when I teach, although this is not, I can say that not published in guidelines or I have not published it number of times. So if I'm doing this M-mode measurement of LA, correct? So this is
Yes, sir.
M-mode. It's not a very clear picture. Let me just try to make this M-mode a clear one. Yeah. Now, can you see this aorta? Ideally, if I'm
Yes.
doing my measurements, they should be leading edge to leading edge, correct? They should be leading edge to leading edge. And this should be leading edge of aortic valve to leading edge. This what should be the measurement is. But number of time what we are doing is when we are measuring LA by M mode, we are not ignoring this. We are measuring this point from this point to this point. Because our LA measurement has to correspond with LA measurement in 2 dimensions. If I'm looking at M mode measurement in 2 dimensions, instead of measuring from this point, I'm measuring this. Although there is not much of a difference. If you look at this dimension of 2 number is 3 and this is 2.83. So leading edge to leading edge, that remains fundamental true, and trailing edge to leading edge remains fundamental true for 2 dimensions.
Oh, yes, sir. And so my last question is about the right parasternal long axis view. Like, when do we take it?
The right parasternal long axis view. We'll show that when we'll come to aortic valve. I can show you right now also. Right parasternal long axis view, you must have the right anterior oblique view.
Yes, sir.
Which one? In which context you are asking this?
Sir, in the first lecture, there was a right parasternal long axis view shown.
Late job. See you later. There's 2 views which we talked about. One is this, and this is one is when we put right anterior oblique view for aortic stenosis. This is ascending aorta. Can you see this ascending aorta? If I put his shoulder behind, I'll just freeze this image for you. And I'll get a pillow for him. I'm putting a pillow behind his right shoulder. Not behind left shoulder, behind only right shoulder. And now look at this image of ascending aorta. I'm trying to keep both the images together. Look at my ascending aorta. Now fully visible ascending aorta. In this, I can't see the free wall of ascending aorta. Here I can see the free wall of ascending aorta. And I can take a real good gradients of aortic stenosis. This is what we coined as right anterior oblique view. Look at this. Beautifully, we can see the ascending aorta. Second thing is what we are talking about is right parasternal window for aortic stenosis again. Room just become into. The camera. Just the camera. Now look at on opposite side. This right parasternal window is like third or second intercostal space where the aorta arises and goes up. So what I'm going to do is keep my transducer at right side of the parasternal window, and I'm going to do this in left hand side. Now I'm trying to focus on my aorta. And when I have to look at an aorta focusing up, now this is my aorta getting focused up. So when I'm going to look at a focused aorta, I always use help of a colors. Because whenever I see a colors away from a transducer, that will be, it should be towards a transducer always. So I'm trying to focus. Now I'm getting it a little better. And this will be very well seen when you see a patient of aortic stenosis. Can't demonstrate a very good, but I'll demonstrate sometime. This is right second intercostal or third intercostal space, and we are able to see a very good ascending aorta. Let me just try in a different fashion. This is known as tracing the ascending aorta. So I'll trace from I've traced. Now you can see the ascending aorta. This is in third intercostal space, second intercostal or third intercostal space. Now you can see this ascending aorta. And if you switch on, this should be a positive Doppler spectrum pattern. This is positive Doppler spectrum pattern. And you know, like, how did I do it? Let me just share you with that also. This is my Plaques window. This is Plaques window, right? You can see aorta in the Plaques window.
Yes, sir.
This is my aorta in the Plaques window. This is my aorta in the Plaques window. So what I did, I just traced this aorta little on the right hand side to open up this my complete aorta. And why these things are needed? You know, the important question is now you can see a complete ascending aorta. And this will be very well seen when we have a good aortic stenosis. Now we are getting a reasonably a good. Can you see the gradient positive Doppler shift? So this is positive Doppler shift of ascending aorta. Right?
Yes, sir. Yes,
I
sir.
know it's difficult,
Actually,
but it will be, once you start doing it, you'll be able to see it better. See the link. Next question, next one.
Dr. Krishna Anshiram Yadav.
Dr. Krishna Yadav, Anshiram Yadav. Dr. Yadav, Dr. Krishna Anshiram Yadav. Dr. Jigna Vignesh.
Yes,
Jigna,
sir.
are you there?
Yes, sir. Yes, sir. Good evening, sir.
Good evening, go ahead.
Yes, sir. Sir, I want to ask, in flex view and in apical three-chamber view, if we are seeing papillary muscle, is it a lateral wall or posterior wall? Because
let's talk of a Plaques view first.
Okay.
Correct?
Yes.
If I'm talking of the Plaques view first, and this is a very intelligent question because majority of time what the people do is, if I happen to see a papillary muscle, this is inferior wall.
Okay.
This is papillary muscle, right?
Okay.
So
Yes.
this is inferior wall. If the papillary muscle disappears, this becomes posterior. Right?
Okay.
Next question.
And sir, how to measure pericardial effusion from subposterior, like in diastole, systole?
Always in diastole, first of all. We'll have this topic when the pericardial effusion will come. Is always in diastole.
Okay, okay, sir.
Because in systole, we have a potential space. It can be seen over here. Look, focus on top. Here is some pericardial space, correct?
Yes, sir.
If I move my transducer during systole, there is a potential space increases. Now look at this, potential space increases. So we always measure during diastole, not in systole.
Okay, sir. Okay, sir. Thank you.
Okay, thank you.
Yeah, thank you.
Next one, Mrs. Jayanti.
Yes, sir. Good evening.
Good evening.
Sir, I have two questions. First is, can you please show me RV inflow and outflow view again?
RV inflow view and outflow view again. Okay.
Yes.
Look, look at my hand movements very clearly. So if you look at my hand movements, what I'm going to do is, I'm going to take this, the footprint looking towards medial sinus. So if I move my footprint towards medial sinus, so in this patient, what do we get? We are getting this RA over here, RV on top. So this is RV RA inflow view.
Inflow view.
Correct. What is outflow view is? Outflow view is when we look at this RV OT over here, and then we see a tricuspid valve and pulmonic artery, this is outflow.
Okay.
And another way of looking at it, I asked you to move your footprint towards mediastinum, that is RVR inflow. If it move it on the opposite side, what will happen? It's not seen in this patient, but the pulmonic artery opens up completely. Now here the pulmonic artery opens up completely. So this is Plaques window. Move it inside RVR inflow view. If it move it opposite side, here the pulmonic artery opens. Now look, see very carefully. I am at Plaques window. Clear? Now with inside medial footprint movement, I am getting RVRA inflow. This is RA, this is RV. Here is RV, and now this is RVOT. Now here is RVOT. So instead of my footprint looking toward mediastinum, my footprint has started looking towards left shoulder. So this is RVOT, outflow type. This view we sometimes takes when we can't find a passive shortness in view at aorta. We utilize this reverse view to look at pulmonic valve breathing. So this is pulmonic valve seen over here. Right?
Yes, sir.
Next
And
question.
the second question is, where can I see LA appendage view?
Wow, good. Two places. From here, go to aorta. And if I aorta come back a little bit, this is aorta. Come back a little bit. Look at the LA appendage. Come back a little bit means here is LA appendage. I'll just look at my movements of the hands. So this is aorta. I've gone to mitral valve level. I'm coming back towards aorta, and I'm able to see a papillary. Oh, sorry, LA appendage.
Okay.
Are you clear or not?
Yes, yes, sir. Yes, sir.
So from aorta, go to mitral valve.
Mitral valve.
Come back to aorta. And you'll be able to see a this thing, LA appendage. Second is,
yes, sir.
You go to apical window. Yeah, here it is. I've gone from 4-chamber view to roughly 5-chamber. Here is LA appendage. Now see,
Okay,
like
sir.
once you start doing it, you start seeing it. Now you can see that I'm a 2-chamber view, but be careful that they should not be pulmonic venous flow, because pulmonic vein would be just behind it. This will be pulmonic vein over here.
Okay.
And here is LA appendage.
LA appendage. Okay, sir.
All right.
Yes, sir. Thank you.
I'll try to show you more nice in a way. All right, we go to next, Dr. Ranjit Mohit Shankar Mohite.
Hello.
Yeah, Ranjit.
Show me again how to calculate stroke volume from VTI.
Okay, good. Stroke volume from VTI. All right. Give me a sec. What all we need for a stroke volume? We need LVOT diameter first of all. I'm going to utilize my equation of the machine now. किसी को मालूम है नहीं आता. So mitral, the aortic valve is mildly opened up. Clear? So I'm going to go to measure. Right side of the screen is visible to you, right? So I'm going to go to dimensions. Then I'm going to go to LVOT diameter. So my LVOT diameter is, this is my LVOT, 2.2. Initially we measured 2.24, 2.23. So 2.2 is my LVOT diameter, correct? Now I'm going to go to 5-chamber view. Take a colors, pulse wave, and LVOT, and now I'm going to trace my LVOT. Trace. So here is my LVOT trace. So if you look at the screen right now over here, we have LVOT VTI, which is, you can't see, you can see. So we have LVOT VTI over here is 20 centimeters. LVOT diameter was 2.2. So what will be the stroke volume? Here is a stroke volume by Doppler is 76 ml of a stroke volume. Index stroke volume is 40 ml per meter square. What is the formula? LVOT diameter divided by 2 will give you radius. Pi r square is 3.14. 1.1 into 1.1 into pi r square is 3.14 into 1.1 into 1.1 into LVOT VTI, that's 20.12. Will give you a stroke volume of 76 ml of this patient absolute value. If you want index, that is 40.43 ml. Is that clear?
Yes, sir. Thank you.
Dr. Pandit. Bhatkar Pandit.
Sir.
Yeah.
Yes, sir. Can you show me the apical 4-chamber, 2-chamber view? How to identify the segments, 16 segments in these previews?
This is 4-chamber. I'm
Yes,
going
sir.
to save it. This is 2-chamber. I'm going to save it.
Yes, sir.
This is 3-chamber. I'm going to save it. And now what I'm going to do is bring out all these 3 views together. So I'm going to bring it views. So 1, 2, and 3, analyze. So my machine has given me all views together. This is 4-chamber view. This is
Yes.
septum. This is lateral wall.
Yeah.
This is inferior. This is anterior wall. This is anterior septum. This is posterior wall. So mid and basal septum, mid and basal inferior wall supplied by RC. Middle basal lateral wall, middle basal posterior wall is supplied by circumflex. Rest all supplied by LAD. When we have a proximal RCA lesion, if you're talking of RCA, middle basal septum, middle basal inferior wall, if I find my RV which is hypokinetic, then we can think possibly patient has got proximal RCA.
Yes.
Clear?
Okay.
Sir, please repeat the blood supply.
Okay, take it again. Have you seen pictures sometime in older formats?
No.
कभी टिकट जब ब्लैक होता था याद है वो टाइम कभी
जी सर
क्या होता था what exactly happened 2 का 4 2 का 4 2 का 4 2 का 4 so one of you should remember middle basal septum, second should say middle basal inferior wall, third should say RCA 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 RCA. Similarly, middle basal lateral wall, middle basal posterior wall, circumflex, 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 circumflex. And last voice comes all LED, all LED, all LED. And if it's proximal RCA lesion, then we have this particular phenomena of RV free wall, which is also hypokinetic along with middle basal inferior and septal segments. Okay. Next question. Dr. Dinesh Tiwari. Dinesh? Dr. Dinesh Tiwari, are you there? Dr. Bhimrao Pawar. B.R. Pawar. Dr. Pawar. Dr. B.R. Pawar. Dr. Rakshit Bhardwaj.
Yes, sir. Good evening.
Hello.
Good evening. Rakshit, go ahead.
Sir, all these views and all the walls, sir, like it's confusing at the start. So how can we make this like get into our minds, like by repeated practice? Any source of material to read is there?
We'll send you this lecture. Listen again and again.
Okay, sir. Then, sir, I have seen my colleagues doing the ejection fraction by the M mode. Is it not correct, sir?
Absolutely non-correct. I'll just tell you answer why. This patient has got some amount of hypokinesis of apical septum. Look very carefully. His apical septum appears to be a little hypokinetic. Right? So what will happen when apex is hypokinetic, the basal segment becomes hyperkinetic. Now let's go to Plaques window. In Plaques window, if I'm measuring M mode over here, I'm ignoring my apical segments completely. So we are only doing ejection fraction across M mode of basal anterior septum and basal posterior wall, which could be normal, whereas the other segments may be hypokinetic. There was a time when there was no 2D was available. Now 2D is available. We always think of a biplane ejection fraction, not uniplane. And truly the ejection fraction should be triplane or 3-dimensional ejection fractions. Okay.
Okay, sir.
Next is Dr. Ankal Patel.
Sorry to interrupt. Hello.
And go ahead.
Sir.
Your voice is breaking.
Sir, I want to see the RVOT diameter, sir, once again.
RVOT diameter. So I'll go to short axis view. This is parasternal short axis view at aorta. These are two cusps for the tricuspid pulmonic valve. A hinge point of one cusp to the hinge point of another cusp will give you RVOT diameter. And then you take an RVOT VTI in the same view. And they'll give you a stroke volume across RVOT. Is that right?
Sir, thank you, sir. Yes, sir.
Okay. Dr. Ankan Patel.
Yes, sir.
Ankan, are you done?
Yes, sir.
Okay. Dr. Nitin Gupta. Dr. Nitin Gupta. Dr. Mohammed Hiru, Al Hiru. Dr. Hiru, are you there?
Yeah, sir.
Go
Sir, can I
ahead,
sir, am I audible?
Oh, more than audible, man.
Yeah, sir. I have some queries, sir. First of all, can you show me, sir, ductal view?
Oh, guy, you're doing a pediatric echo. Hiru, how long have you been doing echocardiography, man?
Sir, I'm working in NICVT for 6 years, sir.
My God. So why did you join this echo course?
Sir, I joined because I previously do your class in Dhaka chapter eco course.
Okay.
So I want to know everything, tips and tricks of your sir.
Okay. You want to become another Rakesh Gupta, right?
उसको ऐसी मजाक में बोला, वापस नहीं आने को बोला, मैंने उसको बोला ना रुक जा करके तू रात को।
अरे भाई रुक जाओ, आप भी बोलना बंद कर दो, आप भी रुक जाओ थोड़ा सा।
गड़बड़ कर रहा था, इसलिए वो मेरी मजाक थी। नहीं, मैंने मजाक किया था उससे और कुछ नहीं।
Okay, what I'm going to do is I've gone to second intercostal space. Can you see my finger? I've gone to almost second intercostal space.
Yeah, sir.
And in second intercostal space, now this is what this pulmonic artery is. Here is a descending aorta. This is ductal view.
So in direction, sir, can
left my transducer remains still at the same place, but only thing is I've gone top up. Look, this is Plaques window, right?
Yeah,
now
sir.
Look at the Plaques window. I'm going much above than that, almost to left second intercostal space, first or second intercostal space. Here is pulmonic artery. You can see the pulmonic artery.
Yeah.
Or you can do this, Hiru. Make a Plaques window and footprint start looking toward left shoulder then.
Okay, sir.
Then you'll find a ductal view. If the footprint would be in left shoulder, then this structure, I'm switching on color. This is pulmonic artery, and this is will be a descending aorta.
Sorry, sir, your voice is not coming. JRP Institute Trina is muted itself.
Mute over sir. No, my voice is there. Can you hear me now?
Yes, sir.
Okay. So go from a Plaques window and look at the cursor. It is looking towards left shoulder. My footprint start looking towards left shoulder. So wherever you see my cursor, that is descending aorta. Wherever you see a color, that is pulmonic artery. And if there is any shunt, it will be seen over here. Right?
Yeah, sir.
Here is. Now you can see a Plaques window.
Okay, sir.
And if I'm looking at the footprint towards left shoulder, this is pulmonic artery and this is descending aorta. Plaques window. Now I'm moving my hand so that footprint is looking towards left shoulder now. From there to left shoulder, and you see a color. That colors are there because of pulmonic artery, and this is descending aorta. Some shunt is present of PDA, which is seen over here.
Okay, sir.
Right?
Sir, yeah, sir. Another thing, sir.
Go ahead.
Sir, another thing. Sometimes we diagnose ASG by sub-Gifford view in bicaval view. Sir, can you please show me in which direction we will
Hiru,
show the bike? Yes, sir.
I'll try because it will not be possible for him to show bicual view. We need a
Sir,
lean
please
and
open your voice. You are muted.
I don't know, like whether you are muted or I am muted. I'm able to hear the voice of everybody.
Yeah, I also hear you, sir.
Yes, sir, we can hear you.
So please check. Somebody is asking my voice is. Please check your own
sir.
voice.
We can hear you, sir.
Yeah, so please check your own voice because something must be there at your end. I'm trying to show you that particular window.
Okay, sir.
So I'm going subcostal window. I'm increasing my depth now and rotate clockwise. Yeah. Possibly we are getting it. Second, lamba सांस लो. So instead of a counterclockwise, rotate clockwise. Here is rotate. Yes, we got it. So when she rotated clockwise, here is SVC and here would be IVC. Here is the interventricular septum. Okay?
Yeah, sir.
So I'll try to show you again. Now look at my probe. Look at my hand now. So I'm rotating my hand clockwise, not in IVC. So I'm opening my complete interventricular septum. Remember this sentence when we have lean and thin person next time. And it's very easy for the kids to look at an SVC, IVC view together. To look at for SVC type of ASDs. That's what exactly you're looking for. Correct?
Yes, sir.
Anything else, Hiru?
Sir, sometimes when we calculated E and A ratio, there is when there is tachycardia usually E and A merge together, and we cannot easily measure the E and A. So what
Right.
should we do in that time?
We know that this is diastolic function in tachycardia. Then we don't take E ratio. We only take E wave. Then we take E prime septal. Then E to E prime septal, if it's more than 14, we consider as elevated LVEDP.
Yeah.
Okay?
Yeah, sir.
That's
Sir,
there in the book. Okay, go ahead.
Sir, another thing, normally when we doing echo, if the patient have normal valve morphology, as we start with pulse wave Doppler or continuous wave Doppler?
Always pulse wave Doppler.
Okay, sir. Sir, another thing, sir, when you doing tissue Doppler, I think you narrow your spectrum of color. Why should you do this, sir?
Increase the frame rate.
Frame rate, sir. Sir, last thing, sir, in many books, when we doing parasternal long axis view, the downward, that is posterior wall, sometimes called infralateral wall. But sir, you call this posterior wall. So what should we tell? It is posterior wall or infralateral wall, sir?
Give me a second. I'll give you the answer. Because till these machines will not change, I'm not going to get changed. That is a nomenclature which has been labeled, three nomenclature has been labeled over a period of time. But the problem with this nomenclature is they have been adopted, they have not been adopted by machines. Right? So
yeah,
give me a second, I'm going to show you what exactly I mean by it. Now, the most important thing is when we look at this nomenclature in these machines, we come back to the same old 16 segment nomenclatures. So that's why we have not changed. At least I have not changed. Many people have changed, but I have not changed over a period of time.
Okay.
So I always say better we remember whatever is there in the machines. Now look, if I say this is says apical septum. Look at the right side of the system.
Yeah.
Then it shows mid septum, basal septum, apical lateral, mid lateral, basal lateral. Similarly, if I go to this basal inferior, mid inferior, basal, apical inferior, and this is basal anterior. So machine, the day machine will change, I'll change. Because if I teach something and machine shows something, that will not be possible.
Okay.
Right?
Yeah, yes, sir.
Dr. Sirisha. Are you there, Dr. Sirisha?
Yes, sir. No doubt, sir.
No doubt. All clear?
Yes, sir.
Ganesh Tukaram Thomore. Dr. Sayali Nandkumar. Dr. Sayali, are you there? Dr. Sumant Kumar.
Sir, no, sir.
Dr. Ishwar Agarwal.
Sir, what is diastolic dysfunction and how do we see for that?
We will come to diastole. Once we finish up this, then we'll start with a coronary artery disease, systolic diastolic functions.
Sir, do you have any recorded video of coarctation of aorta?
Recorded video of coarctation of aorta.
Yes, sir.
Oh, this man has got a coarctation of aorta only, man. We got him stunted.
Okay.
I can show you the stent which is lying over there. So, switch of a colors. Now you see some kind of a hyperacutensity out here.
Yes, sir.
This is stent. And I'm switching the colors. This will have a turbulence seen over here. So what we do is we put a sample volume, pulse wave, prior to the stented part or coarctation.
Okay.
So his coarctation was over here.
Yes.
So we have taken a velocity prior to coarctation. The velocity is only 1.29 meters. If there's a coarctation, what happens? The flow velocity acceleration will happen. So we do a continuous wave down. Now look, its velocity. Velocity is almost 2.5 meters, 2.5 meters. Gradient is 12 or 13. That was 1.5. So that is the difference between two coarctations. But in this machine, possibly we do not have that coarctation. Just let me look at it. And I'll just write it down and send you a very good coarctation of aorta.
Sir, is there any importance of this measurement of MAPS? We have been talking MAPS.
This is old times requirements. You know, now we don't measure MAPS.
So do we really need to measure such things? Because in usual echo reports, we don't see such things, MAPS or something.
Some people have been utilizing it for a long time, so we can't say no to them.
So should we consider it?
I don't use it.
You don't use it? Yeah. Okay, sir. Oh, thank you, sir. Thank you.
Thank you. Dr. Anupa George. Anupa, are you there? Amit Kumar.
Sir, good evening, sir.
Good evening, Amit.
Sir, please show the subcostal coronal view. Please repeat, sir.
It will not be possible. Allow me some time when we come to pediatrics. Okay. I'm writing it. I'll show you in a smaller person.
Okay, okay. Sir, sir, how to calculate the RVSP?
RV?
SP, right ventricular systolic.
Right ventricular systolic pressure, you have to go to tricuspid regurgitation. Okay. Now look at this RV systolic pressure is. Here is TR jet. Can you see the TR jet now?
Yes, sir.
We did a continuous wave Doppler across this TR jet and we got a TR jet velocity, which is 3.48 and 48 millimeters of mercury.
Okay.
Add RA pressure to it. If RA pressure is 10 or let's take 12, this becomes 60. The peak pulmonary artery pressure is 60. Then to drive mean is 0.6 of 60, 36, and plus 2.1. So it becomes 38.1 millimeters of mercury. Less than 25, normal. 25 to 35 is mildly elevated. More than 35 to 45 is moderately and then severe.
Okay. Thank you, sir.
Right. Dr. Umesh Raju.
No questions, sir.
Dr. Safelia Sardesai.
No question, sir.
Dr. Mitul Jain.
Good evening, sir. Could you please talk about RVOT VTI measurement again and its significance, please?
RVOT VTI measurement is we look at the annulus measurement of pulmonic valve. Here is parallel short axis view at aorta. Here is aorta. Here is pulmonic valve. Both leaflets are present. The end hinge point of pulmonic valve. We measure RVOT VTI. Then we RVOT diameter. Then we go to pulmonic valve RVOT VTI. So the sample volume is prior to pulmonic valve, and we trace this Doppler spectral pattern to get a VTI. So pulmonic valve diameter, RVOT diameter divided by 2 will become radius. Then pi r square will give us area. Area into VTI will give us stroke volume. Importance is when we have ASD, VSD, PDA, coarctation of aortas. In those cases, we need to know how much blood which is flowing through pulmonic valve. Is it 2 times of a systemic or 1 less than that? That's how we need all these measurements.
Thank you, sir.
Dr. Namdev Limbaji Chaure. Dr. Namdev. Dr. Suman Chatterjee. Anchala Singh, Dr. Anchala Singh.
Yes, sir. Thank you, sir. Question already answered, sir. Thank you.
Dr. Rahul Gore.
Sir, one question, sir. Sir, in COPD patient, we are not able to get properly apical fourth chamber view. So we get usually use a subcostal view. In subcostal view, how you calculate VTI, sir? We are not parallel to the
VTI of?
Sir, in subcostal view, can we calculate? Can we get VTI, velocity of mitral or tricuspid or?
We can get approximate velocities, but not truly velocities.
Okay, sir. But it is authentic, sir, to put in subcostal view if you get approximate velocity.
Idea should be in subcostal view. Go try to make your image as parallel as possible to flow. All right.
Okay.
Dr. Rahul Gore is done. Dr. Shashank Prabhu Desai.
No question, sir.
Dr. Jai Singh.
Good evening, sir.
None?
Sir, good evening, sir. I want to ask one question.
Sure.
Sir, how can we see maximally length of ascending aorta in Plaques view?
Maximum length of ascending aorta in Plaques window. Okay. Look, this is
Sir,
yeah, go ahead.
and how can we see aorta in subcostal view? And
You went without me.
So what I'm going to do is first look at the maximum length of aorta. So in this Plaques window, I'm going to go towards mediastinum. As I go towards mediastinum, I'll be getting rid of my image of LV. Now you can see a lot of aorta. Can you see the aorta now? Whole of
yes,
aorta?
sir. Yes, sir. Yes, sir.
So it's moving towards mediastinum.
Okay. Right, sir.
Correct. In subcostal view, how do you look at aorta? See the picture. Footprint looking towards aorta. Now look, this is fourth chamber view.
Right, sir.
Correct. Let this footprint looks towards slightly towards aorta. Look, as soon as I say slightly towards aorta, my aorta will open up. Now this aorta is closed. Now this aorta is open.
Okay.
Right?
Right, sir. Sir, can we explain RWMA in M mode also?
Never. Never.
Okay.
Don't learn something which is not right.
Okay. Done, sir. Thank you, sir.
Thank you. Dr. Shrikant Rajvilas Gote. Shrikant, are you there? No question. Dr. Vinay
Yes, sir.
Sharma?
No question.
Okay, dear. Vinay Sharma? Dr. Sharma Vinay, are you there? Dr. Anudeep Reddy?
Sir, no question, sir.
All right. Dr. Karanveer? Karanveer?
Yes, sir. No question, sir.
All right. Dr. Samrat Sukumar Madanik?
Yes, sir. Good evening, sir.
Good
Sir, I
evening.
have a couple of questions, sir. Yes, sir.
Go ahead.
Sir, how do we calculate LA volumes? Are the LA volumes reliable in two-dimensional echocardiography? And my second question is, sir, how to effectively see the pulmonary venous drainage?
Pulmonic venous drainage.
Yes, sir.
Let me just go to two images together first. LA volume is a very good thing which we do in day-to-day practice. Believe my words, there cannot be anything better than LA volume as on today. What we need for LA volume is, can you see my screen now?
Yes, sir. I can see.
We go to 4-chamber view, we go to 2-chamber view. Then we
Yes,
go
sir.
to end systole when LA is maximum in size. As
Okay.
we trace LV, similarly we trace LA from the margins of medial annulus, trace it across it, and go to end of it. And these lines join together. So this becomes area 1, this becomes area 2 in 2-chamber view. And then we look which of these area is smaller. So this area is smaller. So we have taken a length in this area.
Okay.
And this give you LA volumes. And this is
Yes,
very
sir.
authentic as on today in our day-to-day practice. Second important thing LA volume is the LA volume, LA area in both these two views should not have a difference of more than 10%. Look, it's 10.9 versus 10.2. So they are very close
Yes,
to
sir.
each other.
Yes, sir.
So this is very good way of looking at LA volumes today. Your second question
Yes.
was pulmonic veins. Look, pulmonic veins are very good seen in pediatric as well as adult population. And how do we see a pulmonic vein? I'm going to show you pulmonic vein. Give me a second. I'll show live pulmonic vein, that'll be better. This is the turn over.
Yes, sir.
So increase your depth first, and
Okay.
now reduce your gains. Once you reduce your gain, now you can see this pulmonic vein, right pulmonic vein over here.
Right, sir. Yes, sir.
And now switch on colors and reduce your scale to 30 to 40 Nyquist limit.
Okay. Yes, sir.
As soon as you reduce your scale, now you can see colors into this pulmonic veins. This is right pulmonic veins.
Yes, sir. Yes,
So I'm
sir.
going to take my cursor right into this pulmonic vein. Now you
Yes,
can
sir.
see a beautiful systole as well as diastole. So this is
Yes, sir.
systole, this is diastole.
Yeah. That's true. Yes, sir.
Correct. Similarly,
Right,
then I can go to left pulmonic vein. So left pulmonic vein is here.
Okay.
So I'm going to use this color to left hand side now. And this will be a negative Doppler spectrum. Now you can see the left pulmonic vein Doppler flow pattern.
Yes,
This is one, this is second.
Yes,
Only
sir.
thing is you have to increase your depth and reduce your Nyquist limit.
Okay, sir. Yes, sir.
Okay.
Yes, sir. Thank you, sir.
All right, thank you. Next one is Dr. Tamogna Das.
No questions, sir.
No at all.
Yes, sir.
Durgesh Makwana. Dr. Durgesh, are you there? Dr. Kevin Bora.
Yes, sir.
Kevin?
Sir, I am not clear with the measurements of M mode and Doppler values, sir.
M mode and Doppler values means?
Sir, how to calculate exactly the peak gradient or VTIs? I'm clear with the views like the plaques, short axis, long axis, apical four chamber, subcostal and suprasternal. But with the measurements, I'm not sure, sir.
Doppler values measurement, right?
Doppler values as well as M mode measurements, sir.
Let me show you Doppler measurement first. So this is where you get a mitral flow pattern, correct? So this is mitral flow pattern. Same image, you can get an aortic flow pattern.
Sir, how to get these images? Which button should I press during the Doppler? I mean, in the machine.
You were not there in that novology.
No, but I was there, sir. This is, I guess, pulse wave and continuous wave.
Right.
PW and CW.
PW and CW. And third is tricuspid valve. So once you drive these images and get a Doppler spectrum pattern, so once you drive this pattern, then very simple way is you trace this Doppler spectrum pattern. Let me just show you the aortic one. So
sir, what is the time you should press this PW or CW when you put the Doppler?
Normal is when we use pulse wave Doppler spectrum pattern, if the velocity is more than expected, like maximum velocity in tricuspid, aortic is 1.7, mitral is 1.3. If it's more than 1.7, we can switch over to continuous wave Dopplers. But at your level, keep it always pulse wave at a pulse wave level. If it does not contain, the Doppler spectrum is not contained in the screen, then you switch over to continuous wave Doppler.
Okay.
So now I'm going to trace this Doppler spectrum pattern for aortic valve. So I say aortic valve trace. So I'm tracing the Doppler spectrum of the aortic valve across along the line. And what we get on the left side of the screen is all parameters we are going to get it. Here is peak velocity, mean velocity, peak gradient, mean gradient, velocity time integral.
Sir, what do these indicate, these markers? I mean, what do they indicate?
What do they indicate means what exactly mean by what?
What inference do we get from these values and what are the normal values?
Normal values of aortic valve is 1.7. This is 1.5. So normal gradient of 1.7 would be less than 10. So it's less than 10. Aortic valve VTI is roughly 30 centimeters per second. So that's what it exactly means by. If these values are high, it means the valve is stenotic.
Okay.
All right.
So, sir, for every valve, we have to first do color Doppler and then pulse wave, and then we get these measurements.
Always. You don't have to do every valve. Do velocities. If the velocities are high, then only you do this.
Okay. And for M mode?
M mode is, regarding M mode, what do you want to know?
The measurements of M mode, because when a 2D echo report is printed, they mention the M mode values, they mention the Doppler values. So how to interpret these values?
Okay, give me, I'll send you this recording. I will go to M mode and measurements in our Dopplers, in our previous lecture. Just go through that first.
Okay. Right. Thank you, sir. Thank you.
Right. Dr. Ravi Bhushan. Dr. Mahapatra.
Sir, hello.
Yeah, go ahead, Mahapatra.
Yes, sir. Good evening, sir. So normally in day-to-day practice, we do, sir, the LV dimension by M mode and also interpret also the value EF, ejection fraction. So what is your comment? Already you already said about that is not the corrected way, but in normally daily practice, I saw all the whoever do the echocardiography do all the dimension M modes and also interpret the EF by the value.
Well, look, we number of times we have falsely elevated ejection fractions. I've said this question before also. Like suppose you have apical infarct. So if apex is not contracting, what happens? The basal segment become hypercontractile for compensatory mechanisms, right? In those compensatory mechanisms, if I'm doing my M mode, in that case it will be difficult because you will find the M mode ejection fraction is normal when the patient has got definitely a low ejection fraction.
I just said about this normal 2D echo. It's like disease, it's okay. I got your point. But a normal healthy patient, whenever we do the 2D echo and we interpret the M mode, the EF.
How do you say that this person is normal or abnormal?
Hello?
How can you say that this person is normal or abnormal?
By seeing the 2D echo and apical chamber, all the days in eyeball method, normally the first we should appropriately, okay, it's maybe the normal ejection fraction by just the eyeball method.
You can report ejection fraction by eyeball method. I'm not against that, but I'm against M mode ejection fraction.
Okay, okay, sir. And sir, I want to know exactly the M mode measurement of the LV dimension. If you show me again or in next class, whatever sir, to give the.
We have started giving it up completely. I showed you that slide, like where I can show you again also, like we were doing M mode measurements, but we were getting bigger measurements when we were correlating with other patients. So we started shifting over to continuous wave Doppler, this thing 2D measurements. Like I showed you this clip before also. So this is how I'm going to take an M mode measurement across 2 dimensions. Right? That's how you take it.
Sir.
So this dimension is, look, this dimension is how much? 59.5, which appears to be dilated. And why it appears to be dilated is, here I'm cutting mid-anterior septum, here I'm cutting basal anterior wall.
Hello.
Right? And in the 2 dimension of this patient would be 50. I hope you got the answer.
Hello. Sir, just have voice is cut. Hello.
You got the answer or not?
No, sir. I just want to know the exact dimension by M mode in the LV dimension of the by M mode, how to measure and interpret.
We don't measure it. That's what I'm saying. We'll start measuring it M mode dimensions.
Okay.
I showed you this is, if I'm measuring by 2 dimensions 50. If I'm measuring by M mode is 59. So if I measure at 59, it means this patient has got LV dilated. If I go to measure further, this patient has got more than 59, almost 62. Does it mean that he's got LV dilated? No. Why so? Because in M mode, we are not able to cut across basal anterior septum. We are not cutting basal anterior septum. We are cutting mid anterior septum.
Okay.
So stop using it. You know, many people are doing wrong thing. It does not mean that we should start adopting those things only.
Sir.
All right.
Yes, sir. Thank you, sir.
Then Dr. Majrul Islam.
Yes, sir.
Any question?
Sir, I have a question. How to calculate E by E dash ratio?
How to calculate E to E prime ratio? Okay.
Yes, sir. E by E prime ratio.
Very simple. How to calculate E to E prime ratio is this is mitral valve.
Yes, sir.
So what we get E wave. So this is E wave. This is A wave. Now I'll get tissue Doppler imaging. This is E prime. So I'm getting to E prime septum. And the ratio comes up automatically 15.15.
15.1.
Right?
Yes, sir. Sir, one more question.
Go ahead.
Sir, how to calculate the mitral valve area in parasternal short axis view, sir?
We showed you planimetry here. Parasternal short axis view is planimetry.
Yes, sir.
Same thing. Trace the internal border by looking at the opening of the mitral valve. Did you get it or not?
Yes, sir.
Should I show you again?
Yes, sir. Please, sir, show it again, sir.
Can you see this mitral valve which is dancing in between? Can you see now?
Yes, sir.
So I'm going to freeze it, scroll it to the maximum dimensions. So I'm going to trace the area. Start either with medial annulus or the lateral annulus, where medial commission or lateral commission. .39.
Yes.
Do it as many times as possible because the number of times you do, your perfection will come automatically. Look, I'm zooming it up now. Now you can see a better mitral valve. So you were better than before. So do it as many times as possible. I have deliberately omitted this part. It appears to be leaflet which is flail or something like that. I was not happy with this. So I've deliberately omitted this. This is mitral valve planimetry.
Yes.
Dr. Nida Fardeen. Dr. Nida.
Yes, sir.
Nida, you have been present, but you are not asking any question either.
Yes, sir, because I'm unable to see video, so I'm only audible.
Why are you not able to see videos?
So, maybe because I'm using it in a mobile, I don't know. Continuously, I was this happening in the previous lecture also.
Mobile will not be helpful neither.
Sorry?
Mobile does not have that speed. You
Yes,
have
sir.
to have a laptop.
Sorry, sir.
Please get a laptop. That will be easy for you.
Yes, sir. Yes, sir.
Okay.
Sir,
Dr.
I
Sai?
wanted to ask you.
Yeah, please go ahead.
Myocardial performance index. I wanted to ask you how to calculate that.
Myocardial performance index, MPI.
Yes,
MPI is very simple. What do we do is we take mitral flow first. This is mitral flow, right? So the time interval of mitral valve closing and opening time. This is mitral valve closing and opening time. This is 460 milliseconds. Can you see that? 460 milliseconds?
Sir, I am unable to see the video. It's only audible, sir. Yes. So I will look for the video on YouTube, but just let me know how to calculate.
Okay. This is mitral valve closing and opening time. And then we go to 5-chamber view and look at aortic flow velocity, the aortic valve ejection time. So I'm going to take an aortic valve ejection time. So this is aortic valve ejection time. So that was 460. This is 310. So myocardial performance index is 49. So A minus B, A was 460 minus B is 310. divided by 310
upon D.
will give you a myocardial performance index.
And sir, you asked me to remind you about DP and DP by DT.
DP and DT, okay. Let me just look at the mitral regurgitation. I'll show you what is DP DT is. Once. All right, I'm like, you'll not be able to see it, but I'm recording it, DPDT. So what I did is, I have taken a Doppler flow pattern of mitral regurgitation. First point I have measured at 1 meter per second. The second point I have measured at 3 meters per second. So drop of pressure over a period of time is known as DPDT. And once we look at this DPDT, you will find on the screen MR DPDT, which is 931 millimeters per meters, 931 millimeters of mercury per second. That's what the value comes. So we mark at one point of 1 meter per second, and then we mark at 3 meters per second, and that's tell you how much the pressure has dropped over a period of time. You'll see in this YouTube once you go back, right?
Yes, sir.
Right, Nida?
And sir,
Go
yes,
ahead,
sir.
go ahead.
Whenever we take Doppler of any wall, so the sample volume should be at the tip of the wall, or else it can be 1 to 2 mm below or above the wall.
No, it should be just distal to the tip of the valve.
Okay.
If it will be below, what will happen? It will be looking at regurgitation velocity or annulus velocity.
Yes.
It will be away, it will be looking at that particular, suppose pulmonic valve, it will be a pulmonic artery velocity, not the pulmonic valve velocity.
Okay.
It should be just distal to the tip of the leaflet.
Yes, sir.
Okay?
And
Nida,
sir,
is that okay?
IVRT, yes, sir. And how to calculate IVRT, sir?
IVRT is very simple. We take a Doppler, we take a tissue Doppler imaging, and once we take a tissue Doppler imaging, we see closure of aortic valve and opening of mitral valve timer. I have measured it already. It comes out to be 71 milliseconds. Please go ahead and look at your YouTube imaging. Then you'll find it's very simple to look at IVRT. IVRT is isovolumic relaxation time.
Okay, sir.
Right,
Thank
Nita?
you.
Great.
Yes, sir. Thank you.
Dr. Sai Prasad?
No questions, sir. Thank you very much.
Manu Kapil? Dr. Clay?
Yeah, sir. Good evening, sir.
Good evening, Clay.
Yeah, I have one question here. See, can you repeat? Can you show Parasternal short axis view at the papillary muscle? I want to see that.
Sure.
Yeah.
We go from plaques,
Right.
rotate transducer 90 degree, footprint looking towards aorta, we open up aorta, then come back towards left shoulder, then comes left hip. First is this mitral valve, and then papillary muscles. Now you can see the papillary muscles.
Okay. Yeah. Okay. Okay. Thank you, sir.
Thank you. So I hope that's all. We have cleared up everybody's question. Still somebody's questions are left behind. They can send on a WhatsApp or a group so that we can take them later on. So with this, let me finish off my talk today. Long, I know everybody's family must be waiting for them to join. Like your kids must be saying every day, Dad, हर हफ्ते आप पढ़ते रहते हो, कुछ हमारे साथ खेलते नहीं हो. So go and play with your kids and have a dinner with your kids and a wife together and enjoy. Stay safe. Take care. All the best. Good night. Shabba khair. Bye-bye.
Good night, sir. Thank you.
Good night.
Hello.